Dear students, good afternoon. Now I'm here again with another concept, and that is a very important concept, and that is related near to my wrist area of my upper limb. And now I'll be talking about fractures of the lower or the distal wrist, and these are given the name of scaphoid fracture and then the Colles fracture. So, to talk about that, let's start the ball rolling. And to start with, so now I'll be talking about scaphoid and Colles fracture. So now look at it. This lady fall on an outstretched hand. Foosh. Foosh. So she falls here. She slipped. For any reason she slipped. She falls on an outstretched hand. The resultant thing, most likely, because we talk about in our wrist joint lecture that this bone is not in direct contact with the proximal row of the carpal bone. So there are less likely chances of getting fractured. But this is for sure. So there we have a fracture in the distal radius bone, and that is a classic of a distal radial fracture. And now if we look in it, this is a anterior posterior view. If you look in a side view, so you can see that, and it resembles a dinner fork. Everybody knows what a fork is. That's why it's also called as dinner fork deformity. If you can see this in the real x-rays, and you can see here, and you can see highlighted, these are the carpal bones, the metacarpal bones, the lower radius and lower ulna. You can see both the views from anterior posterior and from a lateral perspective. So now let's figure it out. Where are those fracture lines? So just to enhance that, you can see here how the fracture line goes all the way down. This is my anterior posterior view, and this is the lateral view, which is indicating the fracture line. When we are looking at the fracture, we have to be very careful. Along with that, you can also see there is bone density which has been decreased. So some kind of osteoporotic changes are also visible in this particular person. Looking forward. So now this is what exactly, this is a schematic picture where I'll be talking about, and you're looking at the fracture of my distal radius and also the fracture of the scaphoid bone. They can be together. They can be alone. If somebody falls in an outstretched hand, may result only in a fracture of scaphoid, may result only a fracture of lower radius. Guys, scaphoid fracture is not an easy to be detected. I have also emphasized in one of the structure of the week session last week, and I have emphasized that we need to have some special type of images to really, but we need to have a clinical suspicion. If we have the suspicion, then we can connect it. So let's see what happens and how the things have been arranged. So Colles fracture is a fracture of radial styloid or distal radius, and is the most common fracture in adults. Usually happens when you fall on an outstretched hand. And the typical dinner fork deformity, I have shown you dinner fork, everybody knows. There is no need to explain it. Now what happens? So this is the radius. We are good with that. This is its styloid process or the distal fragment, and you can see it's been pushed downwards. Can you see this? This notch part is being going facing downwards. And this is important, and that's the other bone is my ulnar bone. Now this is a fracture site, and there is a fracture, and this is a scaphoid. Why I give it a color? Because there are chances in this bone that it can undergo avascular necrosis. Now what happened? This is the scaphoid which is being fractured. So now the position of the hand at the wrist, it's different, and now it looks more like a dinner fork deformity. So it's a typical dinner fork deformity, and this is what. This is a very important structure which goes by here. We know about it. And this is nothing but my median nerve. So median nerve, can you see that? This sharp end of my distal, which one? Radius bone. Yes. So this can severe, this can traumatize, this can concussed. So there are so many possibilities. So there's a fair enough risk that in this type of fracture, we might have an injury occurring to the median nerve. This is my median nerve, and now injury can cause, and then it can be a disaster. Now, the patient present, what are the sign and symptomatology? Distal fracture. So at the wrist, what we can see the Colles fracture. We call it Colles fracture. And Colles fracture involves, I have emphasized already before, how they present to you. There are losses if some nerve injury is there. What are the sensory losses? Pain and swelling of the wrist. So that is a sensory deficit. May include sensory changes. And what are those sensory changes? Paresthesia, hyesthesia from distribution of the median nerve in the hand. If median nerve is damaged, so there are chances that minimal sensation, and then these are different terminologies which we have to be understanding. And the motor deficiencies, what are the motor deficiencies? We all know that median nerve is done by supplying all the flexor compartment muscles of my forearm. Now it has to only supply what? Yes, thenar eminence muscles. So now dysfunction of intrinsic hand muscles, thenar muscles, and the first two lumbricals. We know that. First two lumbricals and the thenar eminence. They are innervated by the median nerve and the classic dinner fork deformity. So that is, these are the motor deficits. So when we are dealing with any nerve injury, we should look for which part of the nerve is gone, how much is gone, and sensory component is lost or motor is lost or both are lost. So we have to differentiate these features. And then the involvement of the radial or ulnar arteries may impair vascular supply to the hand. So there are fair enough chances that there might be an associated injury of radial artery, because then once there is a fracture, it's not specific that it will involve only median nerve. If the trauma is more, if the impact of injury is more, so we can have more problematic situation. So we should always be speculating, anticipating, and we should be looking for, like, how I evaluate then artery is damaged or not damaged. So I look for peripheral pulses. If pulses are not there, so there I need to be worried for. And that comes with the practice. So now this is a classic of someone. Can you see that? It's something like, obviously it's not a dinner fork itself, but look at his hand. So this is the classic pattern. This is a classic hand. We call it dinner fork deformity, and you can see that the distal fragment of the radius is being pushed upwards. And this, now question is, why is being here? Why is not falling down? So what are those forces? What are those factors which keep this distal end of the radius in its position? And that's a very important concept. Look at it. So it is upwards. The shaft is dropping down, the lower end is dropping down, but this twilight process of my radius, it stays there. So can you tell me what is the reason why it's not falling down? Who's forcing it here? Who's keeping it here? Is there any hook? Is there any anchor? You think this? No, this is not. There is someone else, and that someone else is really important, and you have to think it over, and you have to tell me when you listen to this lecture. Then you have to tell me what are those factors which keep this distal end of the radius stay in their position and it's not dropping down. So that factor has to be known. Look at it. It's a real X-ray. It's a schematic picture. Both of them showing you. So this is a classic of Colles fracture. And now this is the same thing what happens. So now the answer is revealed here. Why this fragment is there, and this is the classic. So it is being posterior displacement of the fracture fragment is caused by traction of, guys, brachioradialis muscle is attached there. So brachioradialis keeps it there. It's not falling down on this because it's attached here. And that's why it's been maintained in this position. It's not falling down like the shaft of the radius bone. That's really important. You need to be good at it. I told you brachioradialis muscle is unique. It has very different orientation. It has very different clinical application. So you are expected to be good with that. Now look at it. See that. This fragment, the bone is falling down, but this is going up. Who's pulling it up? Brachioradialis. Excellent. This has been pulled outwards. So this is a classic of. So what are these? So these are the different presentation. And this is been pulled backwards and laterally. So this concept has to be very clear. How we reduce it? Look, the bone is fractured. The fragments are not there. So we pull it, try to bring these. It's kind of a jigsaw puzzle. So basically we are trying to align. And then look, once it's there, and then we can release it. and this bone goes fine. And then after that, there is a process of bone healing, and then this callus formation, and usually takes 6 weeks. You don't leave a plaster cast, you leave a back slab. I don't know. You have to be going in details of that. Not really. So basically, you're supporting because there is too much edema. If you saw that there was swelling, so if you put in the plaster cast, there are fair enough chances of what compartment syndrome might possible. Other things are possible. So we have to, and even if we wrap it around, so then it will become loose and then it will not serve the purpose. That's why usually we don't apply. First we wait when the swelling subsides, then we complete this plaster. Anyway, this is a more an application type. If you don't know about this point, it's okay. You're not expected to answer exactly on this slide what is happening. Now, same presentation. Someone falls an outstretched hand. This situation, if this is there, we call it Colles fracture. But if it stays there and this everything is reverse, this is this way, this downwards, now this is upwards. So we call it Smith fracture, garden spade deformity. So it's more like, everybody knows what is a spade we use in our gardens. So if that is happening, the lower radius and lower ulna are pulling upwards, that is called Smith fracture. There are other 2-3 more variants, but you're not a orthopedic resident, so you need not to go in those details right now. You'll be learning about this. And then another option that there is an scaphoid fracture is also associated with all these things. So you need to understand, at least if you don't know about Smith, it's okay. But Colles you should be knowing. Scaphoid fracture you should be knowing. Going further, now you can see that what happens here. So that is when the lower end of the radius is falling down, that is called as what? Colles fracture. And if it is going upwards, reverse of it, then we call it Smith fracture. But see, this head stays here, and who keep it here is the brachioradialis muscle that you need to be good at. Look at this. This is a normal X-ray. We saw it before, and all normal carpal bones, but there is the fracture. So I'm sure you have seen this presentation. There's a complete scaphoid, and then you can see that how the fracture has been indicated within this scaphoid. Are we good with that? Perfect. So now this question we have talked about. Now, scaphoid fracture, sign and symptoms, usually pain and swelling, lateral aspect of the wrist. And maximal tenderness where at anatomical snuff. Motor deficit, abduction, radial deviation is difficult. When patient is doing that, you'll experience pain. So this is a mechanism. Fush, you can connect it. Somebody fall on his outstretched hand. Scaphoid fracture is distinguished by maximal point of tenderness in the anatomy. So anatomical snuff box, if you know it, and if your patient complains of severe pain in the base of, because the scaphoid is present in the floor of my anatomical snuff box. If someone elicit with severe pain in the anatomical snuff box, one should think of scaphoid fracture. Now, look at it. This is how this swelling comes, and this is exactly where we learned that this is the location of the anatomical snuff box. Now, this is the situation. You can see that the carpal bone, it is fractured here. This is the radial artery. This is the position of the hand. Looking after, look at it. Scaphoid got fractured. Scaphoid got fractured. Now, every fracture, this is a surgical exploration. You can see the fracture line. Every fracture does not lead to avascular necrosis. This is a normal picture. I told you about there are numerous nutrient foramina. These openings are for what? For the small branches of the artery. They enter inside the bone and supply the nutrition. Now, if the fracture is here, this part get blood supply, this part get blood supply. So there are less likely chances of avascular necrosis. But if fracture is occurring at this place, so now this place has no direct blood supply. This part will survive and this part will go black. Avascular necrosis. So that's important, and we need to understand why this fragment go under avascular necrosis, because a fracture has to be in certain point, and that indicates with the clues. And you can see that how the radial artery through its branches supplies here. And if we have the distal segment, so this is where you can see that this whole thing goes black, means blood supply is not there. Thank you very much. Looking forward for your question tomorrow. Just ask me if you have not understand something. Thank you very much.